Okay, let's get started. I'm Linda Erkely, and I'm the interim director of the UCLA Longevity Center. And we're very excited to have Dr. Pauline Wu join us today to talk about agitation in people with dementia. Now, Dr. Wu is an esteemed geriatric psychiatrist here at UCLA. As a geriatric psychiatrist, that means she had special post MD training in geriatrics and working with older adults and helping them with, mental health problems, dementia, and specializes in this area. And I've known Dr. Wu for many years. She is a great colleague. And I know that she's very active, not only in clinical work, in treating depression, but also as a principal investigator in research in dementia. And she's a specialist also in agitation. So without further delay, I'm going to welcome Dr. Wu. Thank you for being here today.
Thank you, Linda. Thanks for having me. Today we're talking about a semi-difficult topic, and we're talking about agitation and psychosis in Alzheimer's. I'm going to start my presentation by sharing my screen. Oops. Everyone can see that? Okay. All right, so this is our agenda. We'll be talking about some definitions about what kind of symptoms are we talking about for agitation and psychosis, and then we'll move on to behavioral strategies. We'll talk briefly about medications, additional tools, and then next steps. Who better to actually depict agitation than the great Sir Anthony Hopkins? Anthony Hopkins actually stars in this movie, The Father, and he plays a single man with dementia living alone in London. And we're going to watch the trailer of this movie, but kind of just keep an eye out for that. There's a series of scenes that happens that leads the character to question kind of what is real and what is not real. So hopefully this trailer plays.
Date of birth?
Friday, 31st of December, 1937.
You're living with your daughter at the moment?
Yes, until she goes to live in Paris.
No, Dad, why do you keep going on about Paris?
You told me.
No, I didn't.
I'm sorry, Anne, you told me the other day. Have you forgotten? She's forgotten. Paris. They don't even speak English there.
Dad, I'd like you to meet Laura.
How do you do, sir?
I say, you're gorgeous.
Thank you. I must say he's charming.
Yeah, not always. Laura has come round to help you.
I don't need her or anyone else. I can manage very well on my own.
Everything all right?
Who are you?
Actually, it's me, Paul.
Who?
I live here.
What is this nonsense? Anne?
It's me.
Ah, there she is.
Your father seemed a bit confused.
Something wrong?
Where's Anne?
Sorry?
Anne, where is he?
I'm here.
What's the matter, Dad?
Strange things going on around us.
Don't worry. Everything will sort itself out.
Saw it in his eyes, didn't know who I was. It was like I was a stranger to him. Just did something to me.
I don't know what she's cooking up against me, but she's cooking something up.
What are you talking about, Dad?
I'm not leaving my flat! I am not leaving my flat! This really is my flat. Isn't it? You see, the situation is very simple. My daughter is of the opinion that I cannot manage on my own.
I'm so sorry about this.
Why? She understands perfectly.
It's important. I explained it all to you.
Why do you keep looking as if there's something wrong? Everything is fine.
I think she tries to do the best she can for you, Anthony.
Everything will be all right. I promise you.
There's something funny going on.
All right. Fun fact is that Anthony Hopkins won Best Actor for this role, and he's actually the oldest actor to win Best Actor. He did that when he was 83. So aging doesn't always mean that things end. This is one example of kind of remarkable aging, and that he gave one of his best performances. But the movie is poignant, and with the power of movie making, that you can kind of experience what Anthony Hopkins, his perspective is with dementia. So it's out there in the world for people to enjoy it. Uh-oh. Okay, so today we are focusing on the symptoms of agitation and psychosis, but these actually fall under the umbrella of neuropsychiatric symptoms, which can occur in Alzheimer's as well as other dementias. But there are other neuropsychiatric symptoms. We just won't have time to cover all of them. But I did want to just say the agitation and psychosis can be the most challenging, and that's why we're focusing on them today. But these are potentially other symptoms that are referred to all under the umbrella of neuropsychiatric symptoms. So in this presentation, that's abbreviated as NPS. So what are we talking about when we say agitation? Agitation can encompass any of these types of symptoms. Verbal aggression means potentially someone raising their voice, using different language, like using expletives for certain things that, and they never used to talk like that. Physical aggression can mean resistance, so kind of pushing someone away, maybe throwing objects. It can on one extreme be on violent. Otherwise, it can just be kind of the resistance of doing something and maybe posturing, kind of clenching their fists. Those are all examples of physical aggression. And then restlessness is the inability to kind of sit still for long periods of time. So wanting to get up frequently, pace, and again, at the extreme can lead to wandering. When we talk about psychosis, we're talking about either the presence of hallucinations or delusions. So a hallucination is sensing something that is not actually there. One of my patients who lives in California has been telling me that she hears her brother calling her from outside of the house. Her brother, in fact, lives in Maine, and so he is not outside her door calling for her to come out. So she's having what we call an auditory hallucination about her brother. Delusions are different, and these delusions are defined as a false belief not based in reality. Often the delusions that we're talking about relating to Alzheimer's are rooted in memory and confusion. And what I mean by this is that the most common delusion is one involving the delusion of theft. So in actuality, someone can't remember where they put their purse. And because they can't find it, they jump to the conclusion that someone must have stolen my purse. It can get more elaborate than that, involving things that then don't quite make sense. But again, often the root is based on the fact that they can't remember and that they're confused and they just don't know what's going on. The delusions can be fixed, meaning they just have this false belief all the time. It's persistent. And then there are other delusions that might come and go. But the key being they're not actually what's happening. But from the patient perspective, that becomes a sense of their reality. Just one more point to say that agitation and psychosis again, are not always linked together. So some people have hallucinations that don't lead to any other behaviors. They have hallucinations, for example, of little animals that are running around in their room. It doesn't cause any like an emotional reaction. And then some people, again, can have agitation that is related to a delusion, for example. So they're not always linked. Just wanted to point that out. I do kind of lump them together a lot during this presentation, but they're separate symptoms. In fact, 80% of patients with dementia will experience one or more of these neuropsychiatric symptoms throughout the course of their illness. And so what that means is this is actually quite common. So we are not talking about the memory symptoms related to dementia. We're not talking about any of the cognitive, language, multitasking. We're not talking about that. We're talking about these neuropsychiatric symptoms. And the majority of these symptoms occur during moderate to late stages of Alzheimer's. It doesn't mean it can't happen earlier on, but generally the course of their illness, you'll find these more prevalent in moderate to severe stages. And why this matters is because actually there's really a ripple effect of what the consequences can be. The big one being caregiver burden. There is a possibility of an earlier transition to move into a facility. And then there's a lot of increased costs that can be related to the experience of these symptoms. The type of these symptoms also varies with the type of dementia you have. So again, today we're talking about general Alzheimer's, where you can see these symptoms solo in combination, but other people who have Lewy body dementia tend to have more visual hallucinations. They also tend to have a certain type of sleep disorder. In frontotemporal dementia, people typically to have disinhibition, potentially apathy, and in vascular dementia, people tend to have both agitation and/or depression. We're going to spend some time talking about behavioral strategies because that's really at the heart of how to handle this. We do want to consider environmental, what's in the environment that can be contributing. And then we want to also focus a lot about the caregiver and the approach. And we want to consider all these strategies because ultimately we're trying to modify the behavior. Okay, so thinking about if someone is either, are they restless because they're understimulated? They are bored and they have nothing to do, and so that they're confused, and so they're walking around because they're trying to look for something to do. Typically, daily routines are very, very helpful, meaning trying to have a general window of when you wake up, when you have meals, when you go to sleep, and then having a structure in the schedule makes life less predictable. Makes life more predictable. So again, potentially scheduling, lunch with a certain friend on every Monday, or taking a walk always after lunch. These types of activities in the schedule help to minimize kind of anticipation of, potentially what the day is going to bring. And then there's also safety concerns that we should consider, particularly if someone tends to have more of that physical aggression or violent tendencies. And so for safety, that does mean locking away anything that could be used. For example, scissors or knives that they would by default be locked in a cabinet, medications that might be mixed up by accident. And then if there are safety concerns regarding wandering, potentially kind of putting additional locks in the house. So a lot of other safety things to consider. So I'm just kind of touching on them very briefly. Today, what we're doing is really one of the caregiver-focused approaches, because this is education, giving you tools about, how you can respond when you have a loved one who is exhibiting some agitation or experiencing psychosis. In general, it's giving you these tools so that you have a problem-solving approach on how to modify behavior. And we found really simple and direct communication to be the most effective. So simple meaning not giving 4 directions at once, really being clear with step-by-step instructions, and then direct communication such that you're making eye contact, you're not mumbling, and also you're not distracting doing other things, so that they really, kind of know what you're asking and know what you're suggesting. The approach to the response is really key. And when I'm talking to patients who are having these symptoms, I typically will introduce myself and reorient them. Hi, Linda. I'm Dr. Wu, and we're at UCLA. I'm one of your doctors here to help you. So that's an example. But at home, obviously, things are much less formal. So, good morning, Linda. It's Wednesday, and it's noon, so that means it's lunchtime. Will you come down and have lunch together with me? So some orientation of who you are, what's going on, what time of day it is, what days, and this might actually happen throughout the day. This is not just I've introduced myself and therefore everyone is on the same page. With memory symptoms, what you say in the moment is not going to potentially carry on later in the day or even the next day. And so kind of doing this reorientation multiple times may be helpful. Asking people, inviting them to do something typically goes better than commanding people to do something. So as you can imagine, if someone is already angry about something else and possibly accusing you of stealing their money, giving them a list of commands and being angry is not going to go over well. And so again, posing questions, again, and thinking about your word choice, your own attitude, all of these can be helpful. If you're actually trying to do a task, say, for example, it's Wednesday and we take a shower on Wednesdays, narrating what's going to happen in the course of the next few minutes can be helpful. Again, trying to decrease that anxiety and loss of control about, what are you asking of them? And so narrating what you're going to be doing can be helpful. I'm turning the water on first. We're going to let it run and warm up the bathroom. I'm going to pick out your clothes with you. Maintaining dignity by offering choices is also key. Really, as memory symptoms progress, the locus of control will start breaking down, right? And so for most people, that is extremely uncomfortable, not having some sense of control of what's going on. So even offering choices is one way of preserving that dignity. So instead of saying, get changed, you've soiled yourself, it's, do you want to wear the black shirt or the white shirt? And giving them choices can again help the attitudes of getting a task done. Providing reassurance of, again, reminding people that you're on the same team, that you're there to help, and that they're safe, they're in their home. These are types of reassurance that is helpful. And I would also say that avoiding to constantly correct is also part of the approach. So even though you know that the delusions are completely false, in fact, nobody's stealing from them, it is not helpful to kind of repeatedly confront them about how somebody is wrong. So I'm not saying that you should lie to a loved one either, but there are kind of indirect ways to go about it. So instead of saying, "How could you accuse me? I didn't steal your money," you might say, "I know you can't find your money, and you're really, really worried about it." So you kind of want to identify the emotion that goes along with the delusion. And then you can also suggest other ways of, "I'm going to help you look for it later," or "we can call the bank later together and check on your balance." So again, some of these other ways around it, even pushing it to the following day, or pushing some question till later, can help kind of diffuse the tension around a specific delusion. Distraction is ultimately one of the biggest tools for modifying these behaviors, and you want to consider distraction in all senses. This involves getting a snack, putting on some soothing music, getting some fresh air. Maybe if someone is kind of physically agitated, doing some tactile massage, or just changing the activity altogether. And then I would say, from a caregiver perspective, trying to separate the person from the illness is one of the best things you can do to kind of process what's going on. So again, my loved one is not trying to give me a hard time. They can't remember, but it's their illness. It's because of their illness. So again, separating the person from the illness, and that maybe becomes somewhat of a mantra for yourself, of like how to cope with having to keep repeating something, or having to even entertain some of these delusions. You do also want to be suspicious if there's a sudden shift in behavior. Is the behavior possibly symbolic of something else going on? Again, as memory declines, people may not be able to express that they have a pain somewhere. And so it is, could this be possible that they're not sleeping well at night, and that they're more angry during the day because all of a sudden they have pain because they stubbed their toe or something? Could restlessness be a part of a urinary tract infection, such that they constantly feel the urgency that they have to go to the bathroom? So they keep getting up. But in fact, it's maybe part of a medical issue. And ultimately, it is a plea to everybody to kind of keep in mind to be flexible. All of this takes a lot of practice. And I can speak for my colleagues and myself, like we're all still practicing, and what works in one situation doesn't mean it's going to work later on in the day. It may not work next week. And kind of practicing having these tools at your disposal can help you navigate, okay, this didn't work, let me try this. This didn't, and so on and so forth. So the flexibility and really patience is at the heart of it. And it's really hard work that people are doing every day when they encounter these types of symptoms. So there is no one size fits all. I wish I could give that to you, but there's no one size fits all in these behavioral strategies. And we do want to keep the person in mind at heart, and really what happened in their life. And that might give you some clues about maybe what tools are going to be a better fit and what to avoid. So for example, someone who enjoyed art or had an appreciation for art in their lifetime, again, maybe you want to have some kind of simple art materials at your disposal, so that they can that might be one activity for distraction. On the converse, if there was someone who had a traumatic experience with a wild dog when they were little, maybe you want to avoid some sort of like pet therapy situation, for them. So I do think it's, key of knowing who you're with, what they used to love, what they cared about before. But then again, having the flexibility that yes, they loved basketball before and now they're not interested, but maybe there's another maybe there's something else. Maybe there's another sport that they'll enjoy. So those are all examples. We're going to shift to talk about medications. But really the take-home message is that there's a shortage of medications for these issues. And when we say when medications have an indication for something, that means that their medication has gone through clinical trial. They've separated themselves from a placebo. They've gotten FDA approval. That process takes a long time. And really a lot of the medications I'll be talking about, really they weren't developed for these indications of agitation and psychosis, but we are still borrowing some of them to help with these symptoms. But there is no, again, prescription about a one-size-fits-all, because each person's health considerations, what other medications they're taking, and the risks and benefits will really be tailored to the person. And then there are some medications that need to be taken every day, and then other medications that can just be taken as needed. For example, if they have an hallucination only once in a while, that maybe just having medication on those certain days might be helpful, as opposed to taking something every single day. So we're going to go through medications by class. So the first and probably most commonly used medications are still the atypical antipsychotics. There's modest evidence, but they come with a lot of side effects. And so again, these medications are used conservatively, meaning at very low doses and going slow with the titration. And I would say that all medications have side effects. And so, but I would say the antipsychotics tend to have a little bit more. And so again, there's caution in using them, and then sometimes switching. Switching is also done when one agent doesn't work. It's possible to switch to a different one in that family. Just one slide about brexpiprazole. The brand name is called Rexulti. Brexpiprazole is actually the first FDA medication that has been approved for dementia agitation. So this was approved in May of 2023. I've shown this medication in a table with other antipsychotics that are in the same family, just to say that yes, brexpiprazole has overall more modest side effects, but it doesn't mean it doesn't have any. And really, all of these other medications are still used today for other reasons. Sometimes you actually want a medication that is more sedating if somebody is having trouble sleeping, for example. And so, again, there's a lot of individual considerations to see like which is going to be more tolerated. Antidepressants typically have to be taken every single day in order for them to take effect. And they also have a latent onset of action. So usually that means it takes somewhere between 4 weeks plus for the effect to kick in. The results are actually inconclusive in terms of depression, anxiety, agitation, meaning sometimes it works for some people and sometimes it doesn't work for some people. But in general, antidepressants as a class are well tolerated. Mood stabilizers include valproic acid and gabapentin. These typically help in some cases for disinhibition, anxiety, but again, also can have some adverse effects, including sedation and also trouble with balance. Benzodiazepines are a separate class. Typically, these are anxiety-cutting medications. but really they have not been done in clinical trials for agitation. And so while they do cut anxiety, they also have adverse effects, including increasing your risk of falling. They can, in some people, increase confusion. And then in a small population, even though these are meant to help with anxiety, there's a small population that it actually increases their anxiety. So benzodiazepines include medications like Valium and Ativan, Klonopin, Xanax. And then I just wanted to include something about cannabis. This is not a typical medication, obviously, but it is available in California and as medical marijuana. Right now, there are preclinical data in animal models suggesting that there is a benefit for agitation, but it's not been carried over to humans yet. So as of today, there is no good evidence for efficacy in Alzheimer's. And part of the reason of this is that cannabis is actually very hard to study. You know, again, it's legal in many, many states, but federally, it's still illegal. And so, you know, kind of how these trials come about, the ratio of THC to CBD, those differ between trials, the formulations that people are using. So whether they're using a pill or a spray or an oil or a tincture, there's a lot of variability. So again, to date, there is no evidence. But I would say anecdotally, and you might find this on a Facebook group, or you might find this just from a support group, you know, again, people are using it. And part of it is because our pharmacology, you know, has its limits and has its own concerns. And ultimately, I get that families are looking for relief. So it is not something that I prescribe or actually even recommend. You know, the reality is that I'm not able to vouch for kind of what people are buying and what the effect is. But again, it is out there. We're going to kind of shift to additional tools beyond behavioral strategies and medications, because ultimately this is very challenging. A big underscore is to consider your community partners. I'm just highlighting one partner here. This would be Alzheimer's Los Angeles. They have multiple classes, webinars, groups, and I've just listed some of the ones that are coming up that are kind of relevant to this topic. They're open. Some of them are in person, some of them are online. So Savvy Caregivers is a series. There's one very timely, focusing on holiday tips. And then, you know, kind of, again, very similar to the topic we're talking about, understanding challenging behavior changes. So the best way is to go to their website and click under program calendar and kind of scroll to see what, you know, what suits your fancy, what's in your area versus what you can join online. And really, Alzheimer's Association also has a Southland chapter that is very active. And then there are many more, but just to say there, in fact, are a lot of community partners, because no one can do this alone. That's not realistic. It really is, I think, time to think about using your village when you're taking care of somebody who has either psychosis or agitation, because everybody needs breaks. And so using your village, meaning maybe having some hard discussions with your adult children, or maybe with a neighbor, or maybe with, you know, kind of a long lost cousin. But it maybe is, again, the time to think about using the people in your life that you could trust and whether they give some respite. So, you know, can come over so that means you can go out with peace of mind, or that they can just come and kind of keep company for a little bit. Again, I think it's helpful and necessary. Bringing in help also is something to consider so that it is not just you and your loved one. Because a lot of times being able to have another pair of hands or another person to kind of shift activities around can be immensely helpful. Obviously, bringing in help comes with a cost, and that's not realistic for everybody. But again, I think it can be, you can start small. It could be a few hours, 4 hours every Monday, for example, and then building on from then. Also to consider day programs. So again, if someone is really understimulated at home and really isolated because friends are not calling anymore, or they're just kind of withdrawn and socially not reaching out, day programs can be a great resource where someone attends a program between the hours of I don't know. I think there's somewhere between like 9 to 2 or something like that. And there's activities, they're safe, there's staff, there's typically a meal served. So some of these have a per diem cost to them. Some of these, I believe, can be reimbursed through insurance. And so that's something to consider. Maybe having your loved one go to a day program, maybe whatever, two times a week. We are in an area where we are lucky to actually have a lot of support groups. And a lot of these are done over telehealth now. So like this meeting that we're having, that you would sign on to a Zoom. But there are support groups that, are given in different languages. There are support groups for different roles. So there are some that are for adult children, for example, and some for spouses. And really, what is the point of a support group? It's really sharing ideas, sharing that what you're going through is not in a vacuum, and really kind of getting some additional tools to say like, oh, I heard someone try this, let me do that. And also just to kind of recognize the challenges of being a caregiver. So I can't highlight support groups enough. And then if things are getting hard, you do need to include your medical providers about these discussions. And that can be your primary care doctor, it can be your neurologist, and there may be a referral to see a geriatric psychiatrist or a psychiatrist, which maybe then segues to medication. Maybe it segues to, getting some labs done. But having these discussions about what's happening, what you're observing at home is key, and that needs to be communicated to the doctors. So what's next? I'm here to give a plug for participation in clinical trials, because this is really ultimately how we move the needle. We desperately need more medications, more interventions on how to interact with these symptoms that can be very distressing for the patient themselves and also for the people around them. And the only way we do that ultimately is by participating in clinical trials. So there's a website. There's also there's websites. We do have a clinical trial center here out of neurology, looking at Alzheimer's. A lot of these interventions are for cognition, so focusing on the memory symptoms and how to try to intervene and change the trajectory of the illness. But then we also have other trials for many other things. And it's not just for people with memory problems. I would say sometimes there's trials for family members. Sometimes there's trials for people that are just worried about their memory. There's observational things that don't involve kind of taking something investigational, but really just kind of following over time and seeing what's helpful and what's not. And if you are at all interested, you can scan this QR code, and that, I believe, it leads to a place where you can put in information where you might get more information about a clinical trial at UCLA. If you're looking at across the country, you wouldn't look at the clinicaltrials.gov. And then again, one last underscore that really how we all get through is by doing it together. And how do we do that? It's really sharing stories of different experiences. And then by doing that, not making sure that we take care of ourselves. So to try to minimize caregiver burnout is to make sure that the caregivers are really taken care of as well. And that means going to your own appointments and getting your hair done when you need to, and getting a coffee break when you need to. So making sure your self-care is a priority. There's a lot of advocacy work and ways to get involved, ways to volunteer on this topic, with federal funding and kind of what's being trickled down or being held in terms of the research world. There certainly is a lot of advocacy work to be done because this is universal, that we need to kind of make some bigger strides in this area. And then I would say, even getting involved in places like the Longevity Center, where there are programs to help stimulate memory, to help with strategies to preserve memory. Like, these are all ways to get involved. But I can't stress it enough that there's a global approach to this, and also just to say that it's not easy. But hopefully this has been helpful to some of you, and then we can switch gears and open it up for questions. I'll just leave this.
Yeah, thank you, Dr. Wu. That was very comprehensive and thorough. So I'm going to invite people to chat in their questions in the Q&A section, and we can answer those. But I was thinking, yeah, agitation is, as you said, one of the reasons where caregivers really get stressed out, and sometimes they will place somebody in a facility, a residential care facility, because they just can't take it. So it's really important to address this, because it really wears caregivers down, and often, your loved one is not happy when they're agitated either. But I wanted to ask you about their clinical trials at the Easton Center for agitation, or medicines to help with those kinds of problems.
So we have clinical trials going on at all different phases.
Mm-hmm.
So some, again, for early stages, some with zero memory symptoms. Right now, as of this current day, right now, we do not have a specific trial on agitation, but we did, and potentially we will again. And so it's really something that you are free to kind of check in on ultimately what you might be interested in, or what someone might be eligible for, because trials come and go, and yeah, so it's best to kind of just call and ask.
Okay, good. Yeah. And I think too, I want to give a plug for geriatric psychiatry here, because first of all, this is a highly specialized area in psychiatry, right? Dedicated to the mental health of older adults. But one thing really important too is that as people get older, their physiology changes. And so just saying, I'm going to prescribe, hopefully you want to avoid prescriptions if you don't need them. But when you do, it takes really special knowledge of the aging physiology to appropriately prescribe for people. And that's why, in working with geriatric psychiatry for all the years that I did, I really found how important it was to go consult with an expert who is very educated in what it's like to prescribe for someone who's older. So, Dr. Wu, do I have that right, or would you add anything to that? Because I found it,
Yeah, you're hitting the nail on the head. I would say yes, because physiology changes, because people tend to be taking multiple medications for other things. Again, that the knowledge and the interplay of all these things need special attention. And sometimes people have medications started at a different time, and they're just kind of carried over without discrimination. And sometimes actually in geriatric psychiatry, we're actually reducing medications, you know, because they're not necessary, or maybe again that there are unwanted side effects. So that is also part of what we
Right.
do.
Now we have a really good question here. Dr. Wu, would you recommend ECT, or that's electroconvulsive therapy for people who don't know what that is, with dementia patient who is also presenting with delusions and hallucinations?
That's a very good question. In general, ECT in California is very, very regulated and therefore more restrictive than potentially other parts of the country. So there are some trials of ECT for dementia agitation at other institutions where they did find efficacy in those trials. But to replicate that right now in California, because ECT requires capacity, meaning someone needs to be able to understand themselves, risks, benefits, etc. Again, if they do have a moderate to severe cognitive disorder, that becomes very hard, and then it becomes an involuntary process, meaning it has to go through the court. And so just to kind of make the story short, is that it's very challenging. I won't say it's completely impossible, but realistically, that is not accessible for the majority of people to use ECT.
What are the reasons to perform ECT on someone with dementia? Like, is it something that is done? And if so, why? For which
So again,
reason?
in other parts of the country, that's been used in research for these types of symptoms, these neuropsychiatric symptoms, including agitation. But again, those were in studies. So yeah, otherwise it is not an indication. Yeah, it is not specifically an indication in and of itself for ECT.
So who do you typically treat with ECT?
The majority are for mood disorders, and primarily depression is major depressive disorder. Probably accounts for 80 to 90% of of ECT.
Very good. Thank you.
Sure.
Here's another great question from Shelley. Where do sleep problems or sundowner syndrome, where does that fit in to this? Any treatment recommendations for that?
So what we refer to as sundowning doesn't actually always correlate to when the sun goes down. Usually sundowning means that someone is more confused as the day goes on. And so sundowning can in fact occur, at noon. It can occur at 5 p.m. So again, it's just relating to the fact that while someone is awake and as the day goes on and it's later, there tends to be more confusion later on in the day. If there are patterns to when sundowning is kicking in, that is an opportunity to implement something before that period of time. So again, if you have someone who is getting more confused and restless and has a delusion that they need to go home at every 5 p.m., even though they're in their home, but they're having a delusion that I need to go home, there's somewhere I need to be. What you want to do is try to target the few hours before 5 p.m. So you want to target, again, 3 o'clock, 4 o'clock. Some of this may involve, again, some of these behavioral strategies we talked about, putting on, putting on, a comedy or, making phone calls at that time so that people kind of stay in touch with certain people. It could involve pre-medicating that period of time. So taking something at 3 p.m. such that when 5 p.m. rolls around, people are more relaxed and don't get into that frantic state. So Again, so that's a general approach to sundowning. Still, again, not one size fits all. And I would say, sleep is a big topic and something there's not enough time to talk about. But there is not necessarily correlation between sundowning and sleep. I'm not sure if that answers the question. But.
Yeah, I think that you said something that is just 100% true about dealing with these kinds of issues. Is it's really trial and error. You have to find out what works for your loved one. So it's not like anybody's being, vague about this. It's like you have an assortment of things to choose from, and you just have to attempt these different alternatives, and you'll usually will find one that works. One of the things you absolutely should not be doing is getting into arguments and escalating situations with people with agitation, because that is how they can get to become more violent. Is when things start getting heated. So definitely don't want to do that. But one of the questions that people have asked me, and it's out of my wheelhouse, is people get kind of afraid to put a loved one on a medication for agitation, or they'll say, well, do I have to be on it forever? So can you talk a little bit about that?
Sure. So what we typically see is that the agitation can be a phase in itself, so someone who is experiencing agitation now, it doesn't mean that they're going to have this level of agitation or even any agitation forever. And so, again, medications do need to be used selectively, and then also with monitoring, such that, again, whether there are any side effects, again, maybe dosages are reduced, or if, probably every 3 months or so to kind of reevaluate, do we still need this medication, or can we reduce even by half, or can we, or is there something else emerging? So I think having that flexibility, even with the medications, is really quite critical, because the agitation or the psychosis can be a phase in and of itself.
And as you pointed out, it can also vary just in the same day, like around sundowning or pre-sundowning, or there are times of the day when people may be agitated and other times when they're not. So it's kind of a big word, a big umbrella word, but it can have many faces and symptoms of agitation. I think one thing is people don't always realize that their loved one is agitated. Right? When they're getting irritable, they may be agitated. When they can't sit still, they may be agitated. Right? So it's good. Like if Dr. Wu was your doctor or your loved one's doctor, and you want to say, I think they're getting agitated, it would be important to say, what are you seeing that makes you think that? Right? Because it means different things. Yeah, means different things to different people. So it's always good to be specific about the symptoms that you're seeing, which may or may not be agitation. The other issue is medical problems. Like, are there any underlying medical problems that can cause agitation? Not just somebody being, the symptoms, other medical illnesses outside of the dementia?
So again, if there's really an acute, meaning a sudden shift in behavior, for example, someone all of a sudden is very sedated during the day, whereas again, typically they have no trouble with their energy on a random day. You do want to be suspicious of maybe there is an underlying medical issue. And again, they may not be able to reliably answer. And so that might mean, you check what you can. You check, for example, if someone has a fever, you can, again, you see how they do with their appetite, and you want to make your observations about what else is different other than the sedation. But ultimately, if it still kind of remains mysterious, then you want to get checked up. And that means, taking someone into their doctor, maybe urgent care. Not always that easy to get an appointment these days for things. But that's why it's good to have, again, on your radar, either with you and your neurologist or your primary care doctor, who hopefully is very comfortable with geriatric medicine, that this shift in behavior may be separate from the dementia. And so we don't want to miss something that can be treated, that also could fester if we don't attend to it.
Right. That's exactly. It can fester, it can get worse.
Yeah.
Something too that I wanted to share with people is if you're in the Alzheimer's and dementia care program, then you would reach out to your case manager if you see agitation or you see a change in behavior. And then through that Alzheimer's and dementia care program, if any of our viewers today are part of it, you can get behavioral management training. They have boot camps. So it's a UCLA resource. And then somebody emailed me right as we're talking that said there is a community resource in the South Bay, and I'm just going to type it in here. I'm
gonna stop my share if that's okay.
Yeah, we have 2 minutes. So it's called the Dementia Activity Club.
Oh.
And it's Monday through Friday. I'm trying to find, and here's the phone number. And so for those of you tuning in from not on the west side, but on the South Bay side, here you go. And you can inquire about that as well. So there are different resources around. And I think, as Dr. Wu was talking about, these day programs are great. And if your loved one will join one, because you know what? They need a life too, right? They need to have fun too. And we often forget, we forget that even though they're not able to do what they used to do, they still need entertainment and enjoyment, and they need to feel valued. And sometimes, that kind of anxiety, angst, sadness can be the root of agitation for some individuals. So we have a minute left. I want to thank you, Dr. Wu, for being here today and giving us your expert advice and taking some of the mystery out of agitation and how to deal with it. And it seems to me the good news is that there are lots of tools that are available, but people just have to be patient and kind of try them and don't feel like a failure if the first one doesn't work.
Yes, that's really well said, Linda. It's challenging work, and I think we're all human, and so sometimes it is hard not to take these things personally when someone's raising their voice, or again kind of spinning a different story, and again trying to kind of separate of what's the illness here, and kind of what who separating the illness from the person, and really just being flexible about trying different things, and ultimately that you're doing it out of love, and ultimately that we're here to take care of each other, and this is one of the most honorable ways to do that.
Absolutely. And like you said, tap into your village. So thank you, Dr. Wu. It's great to see you.
Oh, thank you.
And thank you to our team, Dee Dee and Olivia and Ernie. And thank you to our viewers. We really appreciate you being here. And we are going to have a webinar next month. So we'll have one more before the year ends. In the meantime, everybody take care. Have a good November. And we'll see you in December. Take care. Thank you, Dr. Wu. Thank you, everybody.
Bye-bye.
Take care. Bye-bye.